Today we're tackling a really fundamental topic if you want to understand how medicines work, pharmacokinetics.
Right. It's basically the journey a drug takes through your body.
Exactly how it moves around.
In this journey, it governs pretty much everything. How fast a pain reliever starts working, how long an antibiotic sticks around. Understanding it is, well, it's key.
Absolutely. So our mission here today is to break down the four sort of core stages of this journey.
Hmm.
Absorption, distribution, metabolism, and excretion. ADME, right?
That's the acronym, ADME.
And by the end, you should have a much clearer picture of what's actually happening after you take a medication, which is, crucial info whether you're deep in your studies or just curious.
Left one.
We're using drug movement through the body as our guide here. So, okay, let's jump in. First stage, absorption. What exactly needs to happen for a drug to even begin its work?
Okay, absorption. Simply put, it's the process of the drug getting into your bloodstream.
The entry point.
Yes, the critical first step for most drugs to have an effect, systemically throughout the whole body.
And we know meds come in all sorts of ways, pills, injections, inhalers. How does the way we take it affect this absorption bit?
Oh, the route of administration is huge. Huge factor. Think about taking, say, ibuprofen for a headache.
Okay, standard pill.
Right. That tablet has to dissolve first, usually in your stomach or maybe the small intestine. Then the actual drug has to get across the lining of your GI tract to reach the blood vessels hiding there.
So it's got a few hurdles to jump.
Exactly. But contrast that with getting an antibiotic through an IV for, a serious infection.
Totally different.
Completely. FARV injection puts the drug straight into a vein, directly into the bloodstream. Absorption is instantaneous. It's essentially 100% absorbed because you skip all those initial barriers.
Makes sense. What about vaccines? Usually an injection in the arm muscle, right? Intramuscular?
Yep, intramuscular or IM. That puts the drug deep into muscle tissue. Now, muscle has a really good blood supply. So that means relatively fast absorption into the bloodstream. Compare that to subcutaneous injections like insulin, often given just under the skin. Absorption there tends to be slower. Why? Well, there are fewer blood vessels in that fatty tissue right under the skin.
Less traffic, slower pickup.
Kind of. Think of muscle like a sponge with loads of holes, and fatty tissue like one with fewer holes. Liquid, or the drug, soaks in faster where there are more pathways.
That's a helpful way to picture it. Okay, what about things like asthma inhalers? Albuterol, for example. That seems really targeted.
It is. Inhalation delivers the drug right to the lungs. From there, it gets absorbed into the local blood supply in the lungs and acts fast on the airways.
So it stays local, mostly.
Ideally, yes. It minimizes how much gets into the rest of your system, which is often what you want for breathing issues. And then you've got topical stuff like hydrocortisone cream for a rash.
Right, you put it right on the problem spot.
Exactly. Topical applications aim for absorption through the skin, usually to work locally without much getting into your main circulation.
So it's not just how you take it, but also things about the drug itself and maybe our bodies that affect absorption.
Absolutely. The drug's form matters. A liquid generally absorbed faster than a solid tablet.
Because it's already dissolved.
Precisely. The active ingredient is already ready to go, ready for the body to pick up. Tablets and capsules need the extra dissolving step.
And I know those labels often say take with food or take on an empty stomach. That plays a role too, doesn't it?
Definitely. Food in your stomach or intestines can really change things. Sometimes it helps absorption, other times it slows it down or reduces how much gets in.
So follow the instructions.
Always. They're there for a reason related to this absorption process.
Our source also mentioned blood flow.
Yes, very important. How much blood is flowing to the place you administered the drug? More blood flow usually means faster absorption.
How is that?
Well, the blood basically carries the absorbed drug away quickly. This keeps the concentration of the drug high right at the absorption site compared to the blood, which encourages more drug to move across.
Like a current pulling things along.
A bit like that. It's why absorption from muscle with its good blood supply is usually faster than from under the skin, which has less flow.
Okay. And the last factor you mentioned was pH acidity.
Right. The pH, the acidity or alkalinity of the environment matters. It can change a drug's chemical properties, affecting how easily it crosses membranes. Aspirin, for instance, is a weak acid. It's actually absorbed better in the acidic environment of the stomach compared to the more alkaline intestine.
Fascinating how all these details matter. Okay, so let's say the drug made it. It's in the bloodstream. Success. What's next on the itinerary?
Now we hit distribution. This is all about how the drug spreads out from the bloodstream to the rest of the body, tissues, organs.
So leaving the main highway and taking the exits.
That's a great analogy. The bloodstream's the highway, distribution is the drug getting off at different exits to reach its destinations.
And I assume, just like absorption, there are things that determine where it goes and how much.
You got it. Blood flow is still a big player here. Organs that get a lot of blood, heart, liver, kidneys, brainus, they tend to get higher drug concentrations initially.
Just because more blood is going there.
Exactly. It's why something like morphine can get to the brain fairly quickly to relieve pain. The brain has a very rich blood supply.
Makes sense. The busy hubs get deliveries first. Now, what about this protein binding thing? That sounds important.
It really is. It's quite interesting. Many drugs, once they're in the blood, like to grab onto proteins floating around, especially one called albumin.
Yeah.
When a drug molecule is bound to a protein, it's kind of stuck. It's usually too big to easily leave the bloodstream and get into the tissues where it needs to work.
So it's inactive while it's bound.
Essentially, yes. Only the drug that's not bound, the free drug, can actually move out and have its effect.
So take warfarin, the blood thinner.
Yeah.
Our source mentioned it binds tightly to proteins. What does that mean practically?
It means if, say, 99% of warfarin is bound to albumin, only that remaining 1% is free and active doing the blood thinning job.
Wow, just 1%.
In that hypothetical example, yes. And it gets more complicated because other drugs might also bind to albumin.
Ah, competition.
Exactly. If you take another drug that bumps warfarin off its protein binding sites, suddenly you have more free warfarin in the blood.
And that could be dangerous.
It could increase the blood thinning effect, potentially raising the risk of bleeding. It really highlights why doctors need to know all the medications a patient is taking. Drug interactions often involve this protein binding.
That's a really critical point for anyone managing medications. Okay, the last distribution factor was tissue characteristics, something about fatty tissues.
Right. Some drugs just really like fat. We call them lipophilic, fat-loving.
Okay.
These drugs can build up in your body's fat tissues, adipose tissue. This fat can then act like a storage depot, a reservoir.
Oh, it hangs out there.
Yeah, it gets stored and then can be slowly released back into the bloodstream over time. Diazepam, which is used for anxiety, is a good example. It's quite lipophilic.
Does that make it last longer? It can contribute to a longer duration of action, yes. And this storage also affects how long it ultimately takes for the body to get rid of the drug completely.
Right, it's got this hidden stash. Okay, absorption done, distribution done. Now the body has to actually process the drug, yeah.
Metabolism.
Exactly. Metabolism, or the fancier term, is biotransformation. This is where the body chemically changes the drug. The main place this happens, the liver.
The body's processing plant.
Pretty much. The liver is packed with enzymes designed to deal with foreign chemicals, including drugs, though some metabolism can happen elsewhere, like in the gut wall or kidneys, but the liver's the star player.
And the main goal is usually to break the drug down so we can get rid of it easier.
That's generally the idea, yes.
Yeah.
Metabolism often converts drugs into forms that are more water-soluble, more polar,
Why water soluble?
because that makes them easier for the kidneys to handle and excrete in urine. Our source mentioned two main phases for this.
Phase 1 and Phase 2 reactions, what's the difference? Okay, Phase I reactions are usually the first step. They involve chemical changes like oxidation, reduction, hydrolysis, basically tweaking the drug molecule structure. Often this adds or exposes a little chemical handle on the drug.
A handle.
A functional group, chemically speaking, makes it more reactive, ready for the next step. A really important group of enzymes here are the cytochrome P450s or CYPs.
Yes. Third of those.
They're in the liver, and they metabolize a huge number of common drugs. So think of Phase 1 as the initial chemical modification.
Okay, initial tweak, then phase 2.
Phase 2 reactions usually involve sticking something else onto the drug, or its phase I metabolite. This is called conjugation. You might attach glucuronic acid, sulfate, other molecules.
Like adding a shipping label?
Sort of. The source mentioned glucuronidation specifically, which happens with acetaminophen, for example. This conjugation step generally makes the whole thing much more water-soluble.
Making it easier for the kidneys.
Exactly. Easier to grab and flush out in the urine. Phase 2 is often about making it excretion-ready.
So metabolism isn't always about shutting the drug down then.
That's a really crucial point. Often it does inactivate the drug, yes, but sometimes metabolism actually activates it.
How does that work?
Codeine is the classic example. It's what we call a prodrug. On its own, codeine isn't a very strong pain reliever.
Right.
But your liver enzymes, specifically a CYP enzyme, metabolize it into morphine.
Ah, so morphine is the active part.
Yes. Morphine is the powerful painkiller, so in this case, metabolism is absolutely necessary for the drug to even work properly.
Wow, so your body's actually making the medicine from the pill you took.
In a way, yes. And beyond activation or inactivation, metabolism is vital for preventing drugs from just building up and up in your system to potentially toxic levels. It breaks them down, gets them ready for removal.
Keeps things in check. Okay, processed and ready to go. That brings us to the final step. Excretion, getting it out.
Excretion, the process of removing the drug and its metabolites from the body. And while there are a few ways out, the kidneys are definitely the main exit route.
The primary removers.
For sure. They act like filters for your blood. They filter out waste products, including drugs and their metabolites, which then become part of the urine. Penicillin, for instance, mostly gets kicked out this way.
Okay, kidneys are number one. What are the other routes?
The liver plays a role here too, not just in metabolism. Some drugs or their metabolites can be actively transported from the liver into the bile.
Bile, which goes into the intestine.
Exactly. So the drug travels with the bile into the gut and is then eliminated in the feces. Cholestyramine, mentioned in the source, works this way. It's actually designed to bind things in the gut and be excreted in stool.
Interesting. Liver doing double-duty metabolism and helping with excretion. I wouldn't have immediately thought of the lungs as an exit route.
Yeah, it's mainly for volatile stuff, things that evaporate easily. Think anesthetic gases like nitrous oxide.
Laughing gas.
Right. You breathe them in, and you primarily breathe them back out. That's how they're eliminated. Deep breaths after anesthesia help clear it faster.
Makes sense. And I guess tiny amounts might come out in sweat or saliva.
Correct. For most drugs, these are really minor routes, but trace amounts can be excreted that way. Alcohol can be detected on the breath, but also in sweat. Some continuous alcohol monitors work that way.
Right, okay. So let's recap the whole journey. Absorption getting in, distribution spreading out, metabolism breaking down or changing, and excretion getting out, ADME. It's quite the system.
It really is a very interconnected journey. And understanding these basics, these pharmacokinetic principles, it gives you real insight into why medicines are given the way they are.
Yeah, the route, the dose, the timing.
Exactly. And it helps explain why different people can respond differently to the same drug. Think about someone's kidney function or liver function. If those aren't working optimally.
It's going to affect metabolism and excretion.
Definitely. Which can change how long the drug stays in their system, how strong its effect is, maybe increase the risk of side effects.
It really drives home why things like personalized medicine are so important, understanding the individual.
Absolutely. And, what we've discussed is the foundation. But then you have to layer on top other factors. Think about age. A baby metabolizes drugs differently than an adult, who metabolizes differently than an elderly person.
Phonetics, too, right.
Yeah.
Some people have faster or slower enzymes.
Huge factor. Genetics plays a big role in those CYP enzymes we talked about. Plus, other diseases someone might have, other drugs they're taking. It all feeds into this complex picture of how a drug behaves in a specific person.
It really makes you think about how intricate the whole process is inside our bodies.
It truly is a dynamic interplay between the drug and the body, constantly in motion.